Orthopedics has undergone a lot of developments and a lot of updates in the last 3 centuries. But do you know the major factor for all these developments? It is because of the advent of wars. And in this session, I'd like to tell you one such war story, that is the infamous war, that is the Crimean War. The Crimean War was fought between the 1853 and 1856, and it was mainly fought between the Russian Empire or the Soviet Union and the Ottoman Empire. During this time, there was a lot of casualties recorded and lot of deaths recorded. But do you know the major killer in this war? It was not any weapon or not any soldier from the Russian Empire or the Ottoman Empire, but it was one single entity, that is a compound fracture or an open fracture. So a lot of soldiers that were present during the war suffered from gunshot wounds or suffered from open wounds, and at that time open wounds had no treatment. So such patients, in them 85% of them had to undergo amputation, and more than 50% even died. So one of the surgeons in the war even stated that the depressed condition of the body, to which the hardships of war had reduced the men, made a severe compound fracture of the femur synonymous with death. So that was the terror of open fractures at that time. So in this session, we'll be talking about the management of open fractures. So management of open fractures has evolved over time. Let's understand the different eras of open fracture management. The first era was during the Prussian Wars or the Crimean Wars that I told you about. That was a pre-World War era. In that time, there was no treatment for open fractures and there was no way of controlling the infection. So in such a patients, preserving the life of a patient became more important than anything else. So this was the era of life preservation, and in such an era, amputation was very high. About 85% of the patient with open fractures underwent amputation. But later on, during the World War I and II, some Napoleon soldiers discovered a concept of debridement. So they started doing debridement surgeries. And also, another gentleman by the name of Lister started doing aseptic surgeries using carbolic acid. So because of this, they could control the infection so that death doesn't occur. So in such a patients, this became the era of limb preservation. So life was being restored, even the limb was being preserved. So this was the era of limb preservation. Later on in the 1930s, Alexander Graham came up with something called as a wonder drug, that is penicillin. And in the 40s and 50s, more and more antibiotics came into the foray. So at that time, infection control became easier because of this antibiotics. Hence, we evolved into an era of infection control during the 1949 time when antibiotics were available. Now coming to the present era. In our present era, we have broad spectrum antibiotics. We have vascular surgeries. We have transfusion techniques that are available. We also have minimally invasive fixation techniques. Because of all this, it is now possible to convert that limb back into a pre-injury level. So that is the present era, that is the era of preservation of functions. So this is now the management of open fractures, which completely focuses on preserving the function of that limb. So let's understand how we are managing it. For that, first let's understand what an open fracture is. An open fracture is something also called as a compound fracture, is something that is a break in the overlying skin and soft tissue. So this skin and overlying soft tissue is getting broken, because of which there is a communication being established between your fracture and your external environment. So this is the fracture area and this is your external environment. So there is a communication between these two areas because there is a break in the overlying skin and soft tissue, and that is an open fracture, also called as a compound fracture. These words are used interchangeably. Now there are two types of open fracture based on how the break in the soft tissue and skin occurs. So see, imagine if a fracture occurs and that fracture fragment is then causing a tear in the skin and the soft tissue, that is called as a internally open, or from within it opens. So this fracture fragment is later causing a break in the skin and the soft tissue. So that is internally open fracture. And another where because of high velocity trauma, there is piercing of the skin and then the soft tissue and then it causes a fracture, in such a case, it is an externally open fracture or the fracture that is opening from outside. So these are two types of fractures. In this case, usually the presentation is more dramatic and the velocity is more. Such cases usually present to us with puncture wounds. Now coming to consequences of open fracture. Why is an open fracture a separate class? Why is open fracture not similar to all the treatment principles of a closed fracture? Is because an open fracture has three consequences. The first consequence is that it causes infection of the bone. So commonly there is something called as a skin commensal. So Staphylococcus aureus, for example, is a skin commensal organism which in the skin is harmless. But if there is a break of skin and somehow it gets to enter into the bone, there it is dangerous. It causes an infection. So if there is an open fracture, that will allow your bacteria from the outside environment to come inside into the bone and cause something called as osteomyelitis. Osteomyelitis meaning osteon, that is bone, myelon meaning marrow, and itis meaning inflammation. So inflammation of the bone and bone marrow caused by this bacterial organism. So that is one consequence of an open fracture. Second is that in a closed fracture, you always treat it by putting a plate, putting a nail and trying to fix it. These plate and nail are foreign objects. Even though we put them in the body, we are assured that there is enough soft tissue envelope and skin that is burying the foreign body and there is no reaction causing it. But in an open fracture, that skin and soft tissue envelope is gone. So if you put your traditional methods of plating and nailing, your chance of infection is very, very high in such cases. Hence, presence of wound can be a deterrent to operative fixation of the fracture. So you cannot use your normal nail, plate and screws, and you cannot do an internal fixation in such cases. Internal fixation is not allowed. So that is something you have to understand. And the third consequence is that there is a problem of union. So normally you're trying to unite the fracture by all your methods, but what happens in an open fracture? So in an open fracture, chances of your malunion and non-union are very high. What are the causes of this? Four main factors mainly. One is a piece of bone is lost. So if you have a fracture and it is communicating with the outside, there is a rupture, you can see one fragment, one butterfly fragment might fly out. And because of this butterfly fragment not being there, the chance of union of such a fracture is difficult because there is a bone gap or a bone deficit because of which union is not occurring. So non-union chances are more in such a case. Secondly, you know that at the fracture site, there has to be hematoma. You know the normal sequence of a fracture union is first there is hematoma formation, then that hematoma forms a soft callus, and then there is remodeling and formation of hard callus. But in a case of open fracture, whenever this hematoma tries to form, it is drained out because there's an open fracture. So all your osteoblastic potential or bone forming potential is lost because hematoma is not forming. So that can cause a non-union. Thirdly, your soft tissue and skin is providing a vascular cover for your bone. So that way there is more vascularity coming in into the bone fracture and fracture fragments. But if there is an open fracture, that vascularity from the soft tissue is lost, which can lead to non-union. And finally, bone also gets secondarily infected, causing an infective non-union. So these four causes are the reason why there is malunion and non-union very high in a case of open fracture. And these are all your consequences of an open fracture and why they should not be treated like a closed fracture and they are a separate entity. Now coming to the etiology, the main etiology why open fractures have evolved and become so high nowadays is because of the fast cars and because of a lot of traffic that is developing. All this leads to high velocity trauma leading to an open fracture. That is why road traffic accidents is the most common cause of an open fracture nowadays. Second, you have penetrating injuries, can be sharp objects causing a penetrating injury, which causes from externally to internal. There is break in the skin, soft tissue, and then a fracture. Then in olden times and even in wars, there is gunshot injuries and blast injuries. Industrial and sports injuries are also a cause for open fractures, and earthquake injuries also have to be taken into consideration. Now coming to the classification. So there is a need to classify the open fractures because they have to be grouped into different categories so that they can be treated equally and they can be communicated well. So that is why there is a need for a classification. And this Gustilo-Anderson classification focuses on a few things. The first one is the amount of skin that is lost. So if the skin is a bigger skin loss or a less smaller skin loss, that is the first thing. Second is how much soft tissue cover is lost. So how much soft tissue injuries occurred is the second thing that is taken into consideration. Third thing, which is very important, is the quantum of infection that is there. So not all fractures or all infections are treated equally. So if a patient has a farmyard injury where the contamination is very high but the skin and soft tissue loss is very minimal, that case is directly grouped in type 3. Even if the skin loss is less, even if the soft tissue loss is less, they are directly grouped into 3 because they have more chances of getting contaminated and more chance of such a fracture going bad. So quantum of infection is the third principle that is taken into consideration, and the fourth one is your fracture pattern. So as you can see here, this is Gustilo-Anderson type 1 where it is a simple fracture and a small wound. As you go further on to type 2 and type 3 A, B, C, which is a subclassification, you can see that the wound size is increasing, the soft tissue loss is more, and the fracture pattern from being simple has now gone into a comminuted type. So you can see here there are comminuted fracture patterns. So this is a Gustilo-Anderson classification. Let's understand each type in detail. So type 1 is a fracture where there is a skin wound less than 1 centimeter. It is comparatively a cleaner wound, and thirdly, the fracture pattern is simple. So in such a cases, the chance of infection is very less. So they are grouped into a category that is type 1, where it is a clean wound and where the wound size is less than 1 centimeter and the fracture pattern is simple. Now coming to type 2. Type 2 fractures, the wound size is more than 1 centimeter. Soft tissue damage is present but not extensively, and there are no flaps or avulsions. So you need to understand the flaps and avulsions are whenever there is a wound, there will be overlying dead skin around here. So there will be a blackish flap type skin available. So if that is not there, that is a type 2 fracture. If avulsion and flaps are there, they get grouped into a type 3. And in this also, the fracture pattern is simple. So type 1 and type 2 are pretty similar, but soft tissue damage is more and the wound of the skin is more than 1 centimeter in a case of type 2 open fracture. So type 3 open fractures has a few features in them. So it can be a high energy injury which is involving extensive soft tissue damage. So that can be one entity. Another is it can be a multi-fragmentary fracture or a segmental fracture, or if there is a bone loss. So this is important to understand. If there is a bone loss, irrespective of the size of the skin wound. So if the patient has a bone loss, so this part of the bone is lost and the wound is small, it could be a puncture wound as well. Even in such cases, it has to be grouped into type 3 because such a wounds won't heal and they'll go into non-union. I've told you in the previous slide as well that if there is a bone loss, healing is not good and non-union chances are very high. So these get grouped into type 3. Other entities are your severe crush injuries, vascular injuries that require repair. So if there is any vascular injury, irrespective of the skin and soft tissue damage, they directly get grouped into type 3 and such require immediate attention by a vascular surgeon. Next one is your severe contamination, including farmyard injuries. I told you in a Gustilo-Anderson classification, quantum of infection is also taken into consideration. So if there is severe contamination like farmyard injuries or any injury where the contamination is high but the soft tissue and skin loss is low, they are also grouped into type 3 directly, irrespective of any other entity. Okay, I hope this is clear. These are your 5 factors. One is when there is an extensive soft tissue damage. Second is when there is a multi-fragmentary fracture. As you can see here, there is a comminution of the fracture fragment. You can see in both these types there is comminution and more fragments are seen of the fracture. So that comes under 3, where there is a segmental fracture, multifragmentary fracture, or also bone loss is included here. Then your crush injuries, your vascular injuries, and your contaminated injuries like Farmad injuries. Okay, so all these come under type 3. But type 3 injuries are again modified and subclassified. So type 3 injuries are subdivided based on degree of contamination, extent of periosteal stripping, and the presence of the vascular injuries. So based on these 3 entities, they are again subdivided into type 3A, type 3B, and type 3C. So type 3A, there is adequate soft tissue cover of the bone despite there being extensive soft tissue damage. So there is extensive soft tissue damage that is seen, but around the bone, the soft tissue is still intact. So they come under type 3A and their prognosis is relatively good. Type 3B, there is extensive soft tissue injury, there is severe periosteal stripping and bone exposure with major wound contamination. So such cases, contamination is high because here both periosteal stripping is also occurred and there is bone exposure. So contamination chances are more high in 3B. 3C is high energy injury with extensive soft tissue damage, and also I'd like to add with it that there will be vascular injury in this cases. So if you have a vascular injury, they directly come under type 3C. Now coming to the management. So why is a open fracture so different from a closed fracture? Because of all the consequences. So what is your crux of management? It is to try to convert an open fracture into a closed fracture and then manage the fracture. Okay, so you have 3 stages of management. Phase 1 is emergency care. First, when the patient falls or has an RTA or a road traffic accident, at the site of accident, how do you manage it? How do you manage it in the emergency department? All that comes under your emergency care. Second is your definitive care. So definitive care is when you take the patient into the operative theater and try to do your wound debridement and your wound management. That comes under definitive care. And later, even the fixation of fracture comes under your definitive care. And post the fixation, your phase 3 is the rehabilitation procedure. When you try to get the patient in the road of recovery, that is your phase 3. Now coming to emergency care. So what happens is first RTA occurs and you see that the patient is in the accident site. What are the first things that you do? So there is profuse bleeding because of the open fracture. First thing you do is you take something like a tourniquet to tie around the limb. So you can take a cloth piece. So you can use a tight circular bandage or even a cloth piece and you tie it proximal to the wound site so that there is less blood that is being lost. So that is the idea behind putting a tourniquet. So that is the first thing. Second is you should try to reduce the contamination by giving a wound wash at the site itself with a clean tap water, and after that you can wrap it in cloth. So in this way you're doing 2 things. One, you're reducing the amount of contamination that is going to occur later by covering it with a cloth. Also the pre-existing contamination to some degree is reduced by a clean tap water wash. So that is your second thing. Third is splinting of the fracture, which is important fracture wise, because more the movement around the fracture site, more damage to soft tissue and skin, and even increased amount of pain. So we are trying to limit all that by splinting the limb. You can splint it using anything. You can get an umbrella, you can use a wooden block, and you can use that and temporarily splint the limb. So splintage of limb is your third thing. Fourth is, if there is a piece of bone that you find that is outside the wound, you should try to keep that, preserve that so that it can be used in surgery later on. You can also give it a wash and get it along to the emergency setup. So these are the 4 things that you can do. After that, the patient comes to the emergency department. So in the emergency department, what are the things that we can do? First, you always look for a neurovascular injury. If there is a neurovascular injury, the patient is directly taken up for a vascular repair because that takes precedent over anything else. Nextly, you try to give a wound care so that you can reduce the amount of contamination that is occurring. This washing of wound is done under aseptic precautions, and after that you can use a sterile dressing. So these are the things that you can do in the emergency department. Splintage is the next thing that you do. So I told you Even the patient is in the accident site, you can do splinters. That can be using all these common items. You can use a wooden block or a pillow or a foot rule or even a folded newspaper or an umbrella. So all these can be used to splint the limb and give it rest. But later when the patient comes to the emergency department, you can use these arm bandages, triangular sling, or in case of a lower limb fractures, you can use Thomas splint and other things to splint a limb. So this is important both in emergency department and in the accident site. Later on, you should give prophylactic antibiotics, usually broad spectrum antibiotics, that is cephalexin. But if it is a high grade injury, you have to give third generation cephalosporins and aminoglycosides. So this is the antibiotics that can commonly be given. Later on, tetanus prophylaxis and analgesics are given. To reduce the chance of infection, the next measure that we take is we administer prophylactic antibiotics. So specifically, broad spectrum antibiotics are given. Cephalexin is used ideally, but if there is a serious compound fracture, more contaminated, such cases we also have to resort for third generation cephalosporins and aminoglycosides. So nextly, tetanus prophylaxis is given, and also analgesics are given to reduce the pain. And after that, you get an X-ray to visualize how the fracture pattern is and what should be the fixation. So these are all the protocols followed in the emergency department. Next, coming to definitive care. So definitive care is always in the operation theater, and before that you need to have a rough idea about how much damage has occurred, that is how much skin is damaged, how much soft tissue is damaged, and what is the fracture pattern, so that you have a rough idea of what the treatment process is going to be. So you take the patient up in the operation theater, and after that two things are done. First is wound debridement, and after that a definitive wound management plan is being set up. So what is a wound debridement? So in wound debridement, you should try to reduce as much, the skin excision should be reduced as much as possible. All the devitalized dead skin can be removed, but other than that, the skin margins should be excised as little as possible. So that is the first rule of wound debridement in open fractures. Secondly is your muscle and fascia. So these can be excised more liberally so that you get a clear area and healthy tissue is there. That's why muscle and fascia can be excised liberally. Third, if there is any badly lacerated tendons that you find in the open fracture site, those have to be excised. And if there are clean cut tendons that are seen, you have to approximate them with non-absorbable sutures so that later on a plan can be done to repair these tendons. But if bone ends are seen, these bone ends, if there are small fragments which are not affecting the fracture morphology, they can be excised. But if those bone pieces have soft tissue cover, they have to be retained. So in case of a fracture, margins of the fracture ends are nibbled. Small fragments which are not important in the morphology or the union are excised, and bone with soft tissue attachments are always kept intact. So these are the basic rules of wound debridement. First is your skin. Skin is excised as little as possible. Then you have your muscle and ligaments. So these can be excised more liberally. Then if you have tendons which are lacerated or which are crushed, those tendons can be removed, but if those tendons are cleanly cut, they're approximated using non-absorbable sutures, so later on they can be repaired. Next is your bone piece. So in the bone fragment area, small pieces which are not important are excised, but if they have soft tissue cover, they are retained, and bone fracture margins are made regular by nibbling them. But if you have a badly injured, unsalvageable limb, it goes without saying that you have to do an amputation. And for an amputation, at least 2 surgeons' advice has to be taken before you make a decision of going into an amputation. Okay. So now, let's understand the definitive wound management. We have done wound debridement. When will we close it? So there are 2 techniques here. One is your primary closure. Second is your delayed primary closure. So in case of a puncture wound or a small wound less than 1 centimeter and 1 to 2 centimeters, their suturing of the skin edges or raising a flap is okay in such cases. But if you have a patient whose debridement has been done after 6 to 8 hours, or in such patients where extensive debridement has been done, in such cases, first you leave the wound open. No closure is done, and daily wash and dressing is done, and after that a delayed closure is done. So a delayed primary closure is done. In this, it is covered with sterile dressing first and later on closure is done. So this is called as a delayed primary closure. This is done in cases where debridement is extensively done or debridement is done after 6 to 8 hours. Now let's understand the algorithm of wound debridement that is followed. So if you have a small puncture wound, in small puncture wounds, it is better to leave it as it is because closure will be attained because it's a small wound. But if it's a clean lacerated wound, such cases you can go for a primary closure. That is, you can clean the wound, remove all the devitalized tissue and getting a primary closure and suturing it. But if you have a doubtful lacerated wound, it is better to observe it for 2 to 3 days. And after observation, you have to determine whether it is infected or not infected. If there is no infection, like I told you in the previous slide, you can do a delayed primary closure. But if there is an infection, it is always better to do a secondary closure. So what is secondary closure? You do not use sutures to approximate the end and close it. You allow it to heal on its own. You can use antibiotics, you can use other ointments to accelerate the healing, but the healing occurs on its own. So that is your secondary closure. Also, if you have an infected wound, it is better to heal it with secondary intention or secondary closure. So this is the algorithm of a definitive wound management. Now coming to fracture management. So as orthopedicians, we are always eager to fix the bone. But you have to always remember that in open fractures, wait for the wound to heal before intervening. So do not jump into fix a fracture. That can be done later on. Your first priority is always wound healing. So what are the things that you can do? If possible, you should always try for non-operative methods. So if the fracture fragment is simple and can be healed with non-operative techniques like cast application, you should always go for that. But if there is extensive damage to soft tissues, it is better to put an external fixator. So you have two types of fixation. Internal fixation is what we normally do. When we put a plate, when we put a nail or a screw into the bone, that is an internal fixation that is done inside. But you can also fix a bone externally by keeping a rod outside, and there are pins that are holding the bone in place, and those pins are attached to that rod outside. So that is your external fixation. Also, skeletal traction is a form of external fixation. So you can use these techniques to hold the bone in place as well as allow wound to heal. What are the advantages? There will be a fixation of the bone because, see, this is a fracture and this is the skin overlying it. So you have a bad wound here. Now, how do you fix it? You put rods in here. They can be pins, and after that, those pins are held with an apparatus here. So that is holding the fracture in place and you're allowing your wound to heal. So there is fixation of fracture and there is good care to the wound. So this is the advantage of doing an external fixation. Now coming to the alternatives that we have or options that we have to fix an open or a compound fracture. One is, if it is a simple fracture, you can put a cast or a slab. But how do you do the dressing? So you make windows. You make windows like this. As you can see here in the diagram, you make windows and you do regular dressings through these windows, and then you close the window after the dressing is done. Every subsequent dressing, you open it and again do the dressing. So this way, you're allowing the wound to heal and the cast is holding the fracture in place for even the fracture to get fixed. So this is one alternative. Second alternative is something called as a pin and plaster method, where first you get reduction of the fracture by using pins. So you put pins here and you get the fracture to fix. After that, you apply a plaster over it so that there is proper alignment, and this way wound healing is also not hindered. So this is normally done in an open and unstable tibia fracture. So this method is a pin and plaster technique. Third one is a skeletal traction, where when you have a fracture, you use rods and you try to pull the fracture. You use a traction set and you try to get an alignment through this skeletal traction. So what is done is, if there is a case of circumferential loss of skin and the wound is big, you apply a skeletal traction. This skeletal traction will help keep the fracture in alignment until the wound heals. So after healing, you can either continue the traction if the alignment is good, or you can remove the traction once the wound heals and do a definitive fixation with a nail or a plate. So in this diagram, you can see this is a distal tibia traction, where if you have a fracture of the femur here, there is a pull from this traction set which is keeping the femur aligned, or even a calcaneal traction can be done. So these are your two techniques by which you can do open fracture healing. Third is the external fixator, which is most commonly used. So this is the most common method to treat open fractures. Okay, so here you have a rod and you have these pins. These pins are holding these fracture fragments, and the rod is giving that traction so that there is alignment of the fracture site. But because of this, your fracture site and your skin is not being affected. So even if you want to do a fixation of plate later on, this site is not hindered, and even healing of the skin is not affected. So that way, an external fixator is an ideal method to treat an open wound. Now coming to internal fixation methods, nowadays as techniques have evolved and as aseptic precautions have become more and more followed, such patients, they also go for aggressive closed intramedullary fixation because these give faster rehabilitation. So nowadays some surgeons also attempt at doing intramedullary fixation even if it's an open fracture, because they believe that their aseptic precautions are good and such patients will get a faster rehabilitation. So this is followed nowadays. Third stage is the stage of rehabilitation. It is similar to even a closed fracture where you try to get active functional movements out of the patient. Now coming to the summary of an open fracture. An open fracture is any fracture in which there is damage to the skin and soft tissue envelope such that the fracture is communicating with the external environment. So that is the definition. Now what are the consequences? The consequences of an open fracture is that they cause an infection because of the entry of bacteria becoming easy. Secondly, your traditional methods of fixing it, like your nail and plate, cannot be done in such techniques because chance of infection is very high. And thirdly, there is a high chance of non-union and malunion. So these are your consequences. Coming to the types, there are two types. They can be externally opening and they can be internally opening based on how the wound to the skin and soft tissue is occurring. Nextly, etiology, people with road traffic accidents, people with penetrating injuries, or ones with blast injuries or gunshot wounds or even earthquake injuries, such patients have a high chance of developing bad open wounds. Also classification, important to remember classification. It is your GUSTILO, Anderson classification. Okay, this is based on four things. First is your skin and soft tissue cover. Second is your fracture pattern. Third is the quantum of infection that is occurring. And fourth is if there is a farmland injury or other things. So all these come into your GUSTILO-Anderson classification. So this is important to know that there are three types of GUSTILO-Anderson: type 1, type 2 and type 3, and type 3 is again subclassified into A, B and C. So you need to remember GUSTILO-Anderson classification. And management is 3 stages. First stage is in the emergency room where you're trying to reduce the contamination by giving a wash, you're putting a tourniquet, you're putting a splintage, and then in the emergency department you're starting on antibiotics and tetanus prophylaxis is given. You also give analgesics and then send the patient for x-ray. In definitive management, first you do a wound debridement, proper wash to the wound and excision of skin as little as possible. Soft tissue excision can be done extensively. Tendons, if they are cleanly cut, have to be approximated, and fracture fragments, if small pieces are there, you have to keep them back and align them. So these are all your debridement methods. And then if you want a definitive wound management, you should go either with primary closure, delayed primary closure, or in infected cases, a secondary closure. Some techniques of surgery that is there are pin and plaster technique, skeletal traction, or also an external fixator, which is most commonly used. Nowadays, you also intramedullary fixation is done under highly aseptic precautions. So this was your management. So that's all about open fractures and their management.